This conference will now be recorded.
Or should we start?
Yes.
Okay, great. Well, good morning, everyone. Thank you for attending the second session of the ASNC virtual CV molecular imaging seminars. We have a very exciting program today, and very grateful that you are all here to join us. This series is going to be taking place over the course of the next few weeks, as well as monthly going forward, starting in the fall. The series includes faculty from many top medical institutions internationally. Currently, we have attendees from 27 countries, making this a very international meeting on a virtual platform. Before we start the talk today, I'd like to remind us of some housekeeping tips. All attendees are muted by default. This is done to help minimize the background noise. Because these are highly interactive sessions, we will also be having a Q&A session at the end of the presentation by chat feature. If there are any comments or questions, please use the chat feature on the GoToMeeting platform, and they will be brought up at the end of each talk. Also to note, these presentations will be recorded and available on the ASNC website for future viewing. Today's talk is going to be on atherosclerosis, part 2. My name is Wunan Zhou. I will be the moderator. Speaker 1 is going to be Dr. Pamela Woodard from Washington University in St. Louis. Speaker 2 is going to be 2 research fellows from Dr. Nehal Mehta lab at NIH, NHLBI. And the discussant today will be Dr. Mehran Sadeghi from Yale University School of Medicine. Dr. Woodard is currently the Hugh Monroe Wilson Professor of Radiology and Biomedical Engineering at Washington University in St. Louis. She is also the Senior Vice Chair and Division Chief for Radiology Research Facilities at Washington University in St. Louis. She is also the Director for Centers of Clinical Imaging Research, as well as the Head of Cardiac MRI and CT. Her research interests are focused on translational imaging and clinical trials, particularly in cardiac MR, CT, and PET. She has been instrumental in the development of receptor-targeted PET radiotracers for atherosclerotic imaging with first-in-human imaging using PET MR. She has also been an important contributor to the novel development of novel tracers with cardiovascular targets in atherosclerosis and the myocardium. Dr. Woodard is a fellow of multiple professional medical societies, and she has published extensively with more than 180 peer-reviewed articles. She also is the holder of multiple patents, including patents on natriuretic peptide-mediated imaging of atherosclerotic plaque, as well as targeting NPR, C and angiogenesis with CANP, comb nanocomplex, and also CANF, cypate, an optical imaging agent. Our second speaker will be from the lab of Dr. Nehal Mehta. He is currently the Lasker Senior Investigator at NIH, NHLBI. Dr. Mehta is also the Clinical Professor of Medicine at the George Washington University, as well as Adjunct Professor of Medicine at the University of Pennsylvania. Dr. Mehta's research interests include inflammation, vascular disease, early atherosclerosis, and cardiometabolic disease. Dr. Mehta is the recipient of multiple awards, including the Bradley Award for Outstanding Clinical Research at University of Pennsylvania. He was the inaugural Lasker Clinical Research Awardee, and he is also the recipient of the NHLBI Directors Award in 2016 as well as 2018, first for the human translational studies of inflammation and atherosclerosis, and then again for demonstrating the reduction of CAD following biologic therapy for skin treatment in psoriasis. He is also the recipient of the Outstanding Investigator Award in 2020 from the American Federation of Medical Research. The two speakers from Dr. Mehta's lab are Amit Day. He is currently a research fellow in Dr. Mehta's lab. He is a graduate of the Seth GS Medical College in India, where he received his medical degree in 2015. His major focus in Dr. Mehta's lab has been to understand how treatment of psoriasis using biologic anti-inflammatory therapy may be associated with reduction in early atherosclerosis. And Dr. Day's plans are to start as a PGY1 internal medicine resident at Georgetown University come in July. The second speaker from Dr. Mehta's lab is Dr. Heather Teague. She is currently a research fellow there. She graduated from the Brody School of Medicine in North Carolina with a PhD in immunology in 2014. Her research is focused on understanding the biologic pathways linking immunology and metabolism in early onset cardiovascular disease and psoriasis, and her plans are to become an independent investigator. Our discussant today is Dr. Mehran Sadeghi. He is a professor of medicine and cardiology at Yale University School of Medicine and staff physician at the VA Connecticut. His research interests are focused on vascular and valvular biology and molecular imaging with emphasis on vascular remodeling, CAVD, angiogenesis, and inflammation. Dr. Sadeghi is the recipient of numerous awards, including the NICOM Amersham Clinical Research Award from ASNC, as well as the Harry B. Graff Career Development Award from the American College of Cardiology. He's also the recipient of the Herman Blumgart Award from the SNMNI Cardiovascular Council. So we're looking forward to an exciting session today, but just as a reminder, our next session is on May 19th, next Tuesday from 11 to 12, and we're looking forward to New Technologies in Nuclear Cardiology Part 1. The didactic lecture will be given by Dr. Albert Sanusis from Yale University. The research presentation will be given by the laboratory of Dr. Sadeghi, also from Yale University. And the discussant will be Dr. Ernie Garcia from Emory University. And this is just to remind everyone that ASNC is invested in research, especially for trainees and young investigators with numerous research grants coming up. And without further ado, I will turn it up to Dr. Woodard. So can you make Dr. Woodard the presenter?
Okay. Well, thank you very much for inviting me. I appreciate being here. This is, I'm talking about something that I really enjoy. So hopefully I can advance my slides. Here we go. So this is, yeah, I have to say that of everything that I do, teaching trainees and then also the research that I do has really been something that is, you know, sort of, you know, adds an additional dimension to my job, which has gradually moved into doing some additional, doing administrative work as well as the clinical work that I do. The research team and collaborators are really key to the success of what I'll be talking about. You can see that there are quite a few individuals listed. It really takes a whole coterie of individuals. You know, if you look in the upper right-hand corner, you can see a photograph of Michael Welch. This is in the conference room that we have our lab meetings in. You can see many members of the team there, some of our trainees, one of our coordinators who helped with an IND submission, the coordinator for the trial, vascular surgeon Mohammed Zayed, who's been very helpful in getting our research subjects, and then Yongjin Liu, who's actually been working with me since he was a postdoc and was working with Mike Welch, and now is associate professor. So he's had a rapid rise in career, and Monica Shokeen as well, who's an assistant professor. She's been working with us. So you can see this whole group of individuals, folks from pathology and immunology who have vascular biology expertise, and then our synthesis chemists at UCSB, who worked with us to develop the original nanoparticle, because this was a project of one of the Penn grants, a program of excellence in nanotechnology initially, and the goal was to use nanotechnology in imaging. So these are my disclosures. The project I'm talking about is NIH funded, and we have a T32. There are a couple of other NIH grants on which I'm MPI. Rob Groppler's PI on one of them, and Vijay Sharma is PI on the other. And I think you'll be hearing from Rob later on in the later on in the sessions. So imaging the biology of atherosclerosis. You know, why do we care? And I know you've heard a lot from Peter Libby on, you know, on some of the molecular biology of atherosclerosis, but clinically, you know, 1/2 of our patients die who have sudden cardiac deaths. They occur in patients who were previously asymptomatic. So you have patients who are able to, you know, are living their lives, and they don't have the ischemia initially. They don't have the angina that one typically associates with atherosclerosis. They die from lesions that aren't flow limiting and haven't given them previous symptoms. They rupture and they cause a myocardial infarction or a stroke. So atherosclerosis is a systemic process, a patient-specific process that is of diffuse inflammation, rupture, repair. And ideally, if you can find targets within the plaque that can tell you about the molecular biology of atherosclerosis, you will be able to have precision imaging and precision medicine that will help you risk stratify patients. And so I think, you know, this molecular imaging allows you to move from beyond the anatomy of the lesion, the stenosis, to moving to understanding what's going on at a molecular level. So this is, and maybe even Peter Libby showed this, this is just on a very basic level. There are 2 atherosclerotic lesion types. You know, the stenotic flow limiting lesion that gives you angina when you play tennis or walk to your mailbox, and then the non-stenotic plaque that is non-calcified and has a tendency to rupture. And so in my day-to-day practice clinically, you can see, you know, this is one example, a patient who has 2 types of lesions. One lesion, which is calcified, but isn't the culprit lesion here. The culprit lesion is further down. This is the left anterior descending coronary artery, and this is a coronary CTA examination. You know, and the second lesion here, though, is the one that's given the patient an infarct, the soft plaque that is non-calcified plaque that's ruptured and is the culprit lesion in this patient. So, you know, and you've probably heard this before, that histopathologically there are, you know, reasons for plaque instability. The things that you look for grossly, you know, are infiltration with macrophages, a large lipid rich necrotic core, and a thin fibrous cap. But at a molecular level, there are biomarkers that can reflect the pathophysiology of atherosclerotic plaque. And here's where, you know, radiotracers can be developed targeting these that tell you something about plaque at the molecular level, might indicate which plaque's vulnerable, which might rupture, and even just from the very mechanistic standpoint, provide you with information on what's going on at a cellular level, so that you know, combinations of these types of radiotracers in animals first, and then in possibly in humans, can let you understand more about the plaque itself, its development, and how you treat it. So things that are targeted in the past include, you know, vascular cell adhesion molecules, VEGF, MMPs. Mehran, I know, has done a lot of work with MMPs. Other people in our group have looked at alpha V beta 3 on endothelial cells. On the vascular smooth muscle cells, what I'll be talking about is NPRC. But the other interesting thing is that NPRC just isn't in vascular smooth muscle cells, it's also in the deep intimal macrophages, which is a really fascinating thing to me. But targeting hypoxia, people have used copper ATSM to look at hypoxic macrophages. CD68 is a possible target. And then chemokine receptors. Rob will probably talk about CCR2. CCR2 is present in macrophages, and we have a radiotracer that targets that. And then other individuals looking at microcalcifications in extracellular matrix. Some people are looking at sodium fluoride. That's a radiotracer that is commonly now under investigation. So atherosclerosis is really, it's a microcosm of complex activity led by inflammation, where you have, monocytes that come in through adhesion molecules and get drawn in through the endothelial cells, into the intima. And then you end up, these macrophages become foam cells as they start to become scavengers, and then become apoptotic as they become hypoxic. So, that plaque hypoxia then starts to cause angiogenesis, and then you have alpha V beta 3, which is involved in that. And then, as I mentioned, NPRC that I'll be talking about is present in the vascular smooth muscle cells, but also in the deep intimal macrophages. And so those are, you could, if, the question that comes up is there some simple, relatively non-invasive way of assessing the state of atherosclerotic lesions in a patient at a molecular level? Can you do this without taking the plaque out, without doing immunohistochemistry? And so here's where molecular imaging comes into play. And so a number of years ago now, I mean, this we're talking about back in like 2003, 2004, we started looking at natriuretic peptide receptors, and natriuretic peptide receptor C is a new target for atherosclerotic imaging. Most of you, the folks who are clinical, have probably heard of ANP and BMP involved. These are the peptides that bind to NPR A, B, and C. There are 3 natriuretic peptide receptors. They're involved in homeostasis and natriuresis and heart failure. So make you pee, BNP goes up when you have heart failure, and CNP was the 3rd of these, and it was discovered in 1990 and found in high concentrations in atherosclerotic lesions. And NPRC is the receptor that CNP binds to. What it's responsible for is vascular smooth muscle cell migration. So it's very interesting. It's present in NPRC, or it's present in the vascular smooth muscle cells, and you also see it in the deep intimal macrophages, but responsible for vascular smooth muscle cell migration. And so in some of our work, this was published in 2016, one of the things we've actually discovered is that we've started publishing in pathology journals because, to describe what we're seeing imaging-wise, looking at the mechanism, going sort of backwards to demonstrate what it is we're actually seeing with imaging. We went ahead and looked at plaque specimens taken from our vascular surgeon at a biobank, and you can see that blue. These are the these are cells with NPRC. They're in the deep intima. They're present in maximally diseased tissue. We discovered that you could look at relative expression, and again, not as much in the media or the superficial intima, but really present in maximally diseased tissue that in the deep intima. And we saw this in our mice as well, our ApoE mice. You could see, but actually this was, I'm sorry, is our Western diet-fed femoral artery injury rabbit model. So our rabbit model, we had a rabbit model where we would create an intimal lesion and then feed them an atherosclerotic Western type diet. It says something about the fact that it's called a Western diet. But anyway, but you can see the macrophages again in the deep intima, and then also the pink is the vascular smooth muscle cells, so some blue in that region, but mostly in the deep intima, and PRC present in the macrophages in that region. And so one of the things that, and this is highly controversial, but I just thought I'd bring it up, that one of the things that Gary Owens and others have talked about are phenotype switching in vascular smooth muscle cells. It's very interesting that the NPRC is present both in the vascular smooth muscle cells and in the deep intimal macrophages. And so the question is, is this marker on the same cell essentially that has done some phenotype switching, sort of starting at the deep intima, or starting in the vascular smooth muscle cells and moving into the deep intima. So we use for our imaging agent a fragment of the of CNP. It's a 15 amino acid fragment, and essentially use this. This is not vasoactive. The full length CNP protein is or peptide is vasoactive. And so that the fragment CANF, which is a small component of that, is not, and that's what we use. We've radiolabeled it and have put an nanoparticle on it to bind to the receptor as an imaging agent. And so we've worked with Craig Hawker, who is a synthesis chemist at UCSB, and his group had developed a nanoparticle. And the nanoparticle looks like this. The nanoparticle, it's interesting, it's a comb with a methyl methacrylate backbone and then polyethylene glycol arms. And this assembles into a stellate structure. And so it's this nanoparticle that we put the CANF on. You can see the little green areas there, that's the CANF, and then that's radiolabeled with copper 64. So we did have to optimize the comb and development to try to determine what percent of particles needed to get onto the structure. Looked at 5%, 10%, 25%, and then ultimately looking at binding capacity, focused on the 25%, because you can see that in the cell studies that the best binding capacity blocked well with also. And then, given that I don't have a lot of time, kind of summarized about 7 years worth of work, on this one slide. Performed injury studies in our rabbit model. Rabbits that were fed the Western fed diet, looked at hind limb angiogenesis model, looked at gene expression, and did biodistribution. And the biodistribution was fairly important in getting this into human subjects. Looked at dosimetry. One of the things I should point out is that, if you can inject less than 100 micrograms of the agent, you can go for an EIND with the FDA as opposed to a full IND. And the exploratory IND allows you to essentially assess safety in a rodent model without moving to a larger model. Usually require both. But so we were able to do all of our toxicity testing and biodistribution in mice. And so the critical organ here it turned out to be the bone surface, less of an issue when you're looking at adults, and also the heart wall. And it was excreted principally through feces. So in comparison to urine, which is expected, the methyl methacrylate with the PEG, the polyethylene glycol arms, gets trapped in the liver and excreted. So we were able to determine that there was no significant toxicity, and went ahead and put together INDs for movement into humans. These are all the SOPs for the IND for movement into humans. So, just at UCSB alone, we had developed 70 SOPs. So it's a relatively arduous process, but it's something that can be done, especially if you have experts. We have Sally Schwartz at our place, who's very familiar with FDA. But there are certain steps that you would need to take. And, if anybody's interested in something like this, I'm happy to communicate with you offline about how you would end up trying to get a radiotracer into human subjects and what types of things you need to do. Rob Groppler later on in the sessions is going to be discussing this as well. So this is our original submission to the FDA, and this stack over here is our answer to all of their queries. So, and this is our coordinator who helped to submit all of this to get it into the deadline that we had imposed upon ourselves to the FDA. So right now we're in a clinical phase 1 trial, and our goal is to determine which asymptomatic patients with significant carotid stenosis might have vulnerable plaque and might benefit from carotid and artery intervention. And so we've hypothesized that the uptake of the radiotracer will correlate with the presence of the NPRC on immunohistochemistry. And these are in ex vivo carotid specimens in patients who go on to carotid endarterectomy, and then we get their specimens after surgery. So right now we're in the middle of or actually say towards the end, we're heading towards the end of our first in-human carotid PET MR study. Patients undergo a carotid PET MRI, and we then get their plaque. And then, so we've taken their plaque and we compare the PET SUV of the plaque compared to the NPRC cell count, readout on immunohistochemistry, and then perform both immunohistochemistry and cell counting. And so one of our postdocs, or one of our I should say, our BME students has developed a supervised classifier program to help segment MRI so that we can look at the different plaque components and compare the volume of the different plaque components on MRI also to the presence of SUV. So this is an example of one of our patients. You can see uptake in the right common carotid artery. Here it is again in comparison to the left that has none. So I mentioned bone. NPRC does seem to be present in bone, and so we do see this in patients who have a degenerative change in their spine. So at this point, we have 42 patients. They've undergone the PET MRI. We've had 37 patients who have undergone, and actually, I'm sorry, this is a little lower. It's like 15 patients have undergone the endarterectomy and plaque collection, and then 11 of those have undergone the plaque staining and cell counts. And we have had relatively good correlation between the SUV and the cell counting. This is our current data analysis, fairly good correlation, and also relatively good correlation with MRI. The MRI components, we need to finish analyzing this, and I think that as we go on, given the MRI quality isn't as, some patients move, my guess is that this R value will ultimately be lower. So some examples, you can see uptake in, this is a patient with a very large plaque, but you can see that a lot of the uptake is in the shoulder regions at the edges of the plaque. This is the same patient, same plaque. This is the more distal component of the plaque, and this is the center of the lesion right in the middle of the plaque. So the uptake doesn't always occur right where the lipid-rich necrotic core is. It occurs often in the shoulder regions. And we've been able to get ex vivo specimens, and we can see nicely, H&E, the VVG, but also macrophages in the plaque in the deep intimal region, and then NPRC. and nice co-localization demonstrating presence of the NPRC on the macrophages. Also been able to do autoradiography. And autoradiography is a good technique so that you can demonstrate blocking. So demonstrate that the radiotracer is actually being taken up in the regions that you anticipate, and then to go ahead and block with cold CNF comb. So in summary, the research component, the CNF comb does correlate well with the presence of its target NPRC. Ultimately, clinically, outcome studies are going to be key in helping us determine the value of this radiotracer as a predictor of outcomes. And so we're continuing the data analysis. We're assessing tissue samples for the presence of NPRC. And long-term, we really need to look at patient outcomes, as I mentioned, maybe do a multi-center trial, and that will be our next grant submission. So in general, just kind of tying this back into everything, being able to image atherosclerosis at the receptor and cellular levels will hopefully allow us to better understand atherosclerosis overall, both the cellular level imaging and then also for development of targeted precision medical therapies. So thank you.
Right, that was an excellent talk. So maybe rather than having Dr. Sadeghi ask some of his questions, I wanted to prioritize the participant questions, Dr. Woodard, if that's okay.
Sure.
So we actually have 3 questions in the chat box. So the first one is why to use a nanoparticle with slow blood clearance instead of the polypeptide as the tracer?
Yeah, so that's a very good question. And it's multifold. So initially when we, and I didn't show slides on this, when we radio labeled CANF just alone, we got very, it was taken up by the receptor, but rapid washout. And so our goal was to try to see if we could increase binding capacity by increasing the intravascular half-life of the radiotracer. And we went with a nanoparticle because we actually had 2 Penn grants. We had a Program of Excellence in Nanotechnology grant twice. And in the first grant, you could say it's a very practical reason. It's like, I guess if you have a hammer, what is it? Everything's a nail. We had a lot of synthesis chemists who are developing nanoparticles, and this was part of a Program of Excellence in Nanotechnology. So we went with a nanoparticle that we felt would help us attain a longer half-life. Didn't go with a larger molecular agent, principally because of that grant. In addition, we also, in an application for the second Penn grant, and these were sizable, 18 million was one of them. So, we had a need for an increased intravascular half-life, but also had a large nanoparticle chemistry group.
Great, excellent. The second question is, has it been shown that patients with a positive scan have increased risk of stroke?
At this point, we haven't shown that yet. So that's step number 2. We're actually now going backwards and looking to see in the patients that we've currently imaged, which patients have later on developed stroke. But the next phase of this, this is a phase 1 study for the FDA. Phase 2 will have an outcomes component because really that's sort of the proof of the pudding for this. In other words, when you have a negative study, what's your window of warranty? Can you say that somebody, because a big thing is patients who have 70% diameter stenosis or greater, even if they're asymptomatic, it's sort of at equipoise as to whether or not they should go on to surgery. I mean, guideline documents, NACIT suggest yes, but then other documents, anecdotally, people said, well, it's just such a small percent of patients who go on for stroke with 70% diameter stenoses. How do we know who to take to the OR and who not to? So if you could have something that it could at least give you a negative test and say, it doesn't look like you have vulnerable plaque. Let's, watch you for 6 months or a year and re-image.
Right. Great. And the last question is actually a nice follow-up to that question. And it's really just asking about how do you envision the clinical use in a real-world setting? So in other words, the clinical translation and what type of patient population.
And that's a very good question. I mean, PET certainly isn't going to become the next screening test. It's not going to be everybody who's a smoker and has diabetes is going to undergo this test. It's going to be patients who by ultrasound or other imaging modality have like a 70% stenosis. And the question is, who's going to go to the OR and who's not? And these will be asymptomatic patients. Obviously, if you're symptomatic, you go to the OR. If you're asymptomatic, I've had a patient who said to me, there's only some way of telling me, he goes, I feel fine. He goes, I don't want to have surgery. But Dr. So-and-so is telling me that I should. If there's only some way that I could know if I was going to have a stroke next week, I'd go the week before. And it's like, yeah, there's nothing that could tell you that. But to be able to kind of risk stratify patients further beyond the anatomy, I think is the goal of molecular imaging. So I think that's how it's used.
Okay, wonderful. Well, thank you for that fantastic talk. Dr. Sadeghi, if you don't have any other questions, we'll just move on to the next speaker since we're running a little bit short on time.
Sure, we should probably move to the next patient. I have a ton of questions, but we can ask them later. And in fact,
okay, great.
Yes.
While our speaker is loading up, this is Sharmila Dorbala. Please type in the chat box what country you're joining this seminars from.
Hi, Amit. We can see your screen. Looks good.
Sounds great. Can you hear me?
Yeah. Yes.
Yeah.
Okay,
Yes.
Thank you. I think I can start, if okay. Is it okay if I start?
Yes, please start, Amit.
Okay, thank you. Thank you so much. I think first, thanks for such a wonderful presentation, Dr. Woodard. I think that was great, sort of understanding the pathophysiology of atherosclerosis and so on and so forth. So thank you. And thank you for this opportunity to present at ASNC 2020. I, along with my co-fellow, Dr. Teague, over the next set of slides, will sort of try to show how psoriasis, autoimmune skin disease, can serve as a model to study the relationship between inflammation and cardiometabolic diseases. So here in this slide, as you can see on the left, there is a psoriasis patient with thick, scaly, beefy plaques. On the right, what we show is that psoriasis patients are not only associated with higher cardiovascular events, but these higher cardiovascular events actually tend to translate to 5 years of life lost in a psoriasis patient when compared to an age and gender matched healthy control. Now this association between psoriasis and higher cardiovascular disease can be broadly, but not limited to, categorized into these three bins, which has been the focus of our lab. One being systemic inflammation with immune activation, the second being metabolic derangement, and the third being lipoprotein dysfunction. This slide, I think it's very important that I do justice to this slide. Shown here are two natural history studies, natural history cohort studies. The top one recruiting psoriasis patient. The second one, a comparator study recruiting subjects who are healthy, diabetic, as well as with prevalent coronary artery disease. And most importantly in this study, patients returned during a flare of the disease, providing critical data on what happens in these psoriasis patients when they experience an immune, or if I may say, a cytokine storm. Finally, these patients are deeply phenotyped. Images are obtained, or if I may say, vascular images are obtained using PET-CT, a PET-MR, and finally a coronary CT angiography at all the imaging visits that are shown in green, so which means baseline, 1 year, and then finally at 4 years. we assay their blood for HDL function, inflammatory mediators, and also isolate cells from whole blood. And then finally, in a subset of these patients, we obtain skin and adipose tissue for deep characterization. Now, our second protocol, which is the one in healthy controls, some diabetics, and prevalent CAD, will have all of these procedures and will help in providing contextual data or contextual findings for our psoriasis patients. This is the vascular imaging approach that we take in psoriasis. One may call it a effect and cause relationship, whereby we image all our psoriasis patients using FDG PET-CT scans in order to estimate inflammatory burden in their aortic vasculature. And all these patients also undergo coronary CT angiographies to estimate coronary artery burden in the three major epicardial coronaries, to identify plaque prevalence, as well as different high-risk coronary components in their coronaries. These are the two seminal studies. These are the two seminal initial studies that Dr. Mehta led, which prompted the question how psoriasis can be used as a model to study this relationship between inflammation and cardiometabolic disease. As you can see on the left, psoriasis is actually more than skin deep. One may say that compared to an age and gender matched control, psoriasis patients tend to have increased FDG uptake in their liver, in their brain, but more so in their aortic vasculature as well as in their femoral arteries. The one on the right shows how a psoriasis patient has increased FDG uptake, which is significant, in the cross-section of their aortic arch compared to a control patient which does not have increased aortic FDG uptake. Finally, the graph depicts how psoriasis skin disease severity, as indexed by Psoriasis Area Severity Index score, linearly associates with this aortic FDG uptake, and this relationship persists even when adjusted for age and gender, as well as Framingham risk score, meaning that as the psoriasis skin disease tends to go up, so does their aortic vascular inflammation. So our next question was based on our initial findings, where we asked the question, what happens if we follow up these patients at 1 year? Just to remind you, again, ours is a natural history cohort study with an intention to treat. So patients come in at baseline and receive some form of treatment to treat their skin disease, be it topical treatment, be it light treatment, or be it systemic anti-inflammatory biologic treatment. So we followed 115 patients at baseline over 1 year. And we asked the question, does treatment of their skin disease associate with improvement in vascular inflammation at 1 year? And what we found was that indeed, the improvement in PASI score, or the psoriasis skin disease severity, linearly associated with improvement in their aortic FDG uptake at 1 year. And this relationship persisted even when adjusted for traditional risk factors at baseline, and also change in any of these risk factors over 1 year, if any. And furthermore, on limiting these analyses to patients that were only on anti-TNF biologic systemic therapy, we found an even greater change in their vascular inflammation at 1 year. For example, when we treated all these patients, when we followed up all these patients over 1 year with any form of treatment, the change in aortic inflammation, aortic vascular inflammation, was around 6 to 8%. However, with anti-TNF therapy, that change went to 20%. And what we found that was this improvement in psoriasis skin disease severity robustly associated with this improvement in vascular inflammation at 1 year with an even greater beta value. So now that we show that indeed these psoriasis patients are systemically inflamed and have higher aortic FDG uptake, or if I may say higher vascular inflammation compared to healthy controls, we focused on what happens in the coronaries, or what happens in the coronaries of the psoriasis patients when compared to a control patient. So we asked this question, is coronary artery burden also higher in the psoriasis patients compared to controls? And if yes, then how does it associate with their psoriasis severity? So we accrued 100 psoriasis patients and compared them with 25 age and gender matched healthy controls, and also compared them with 105 10-year-older hyperlipidemic patients. What we found that was indeed psoriasis patients had higher coronary artery burden compared to age and gender matched controls. However, compared to 10-year-older hyperlipidemic patients, psoriasis patients actually had similar coronary artery burden levels. Moreover, this increase in coronary artery burden in psoriasis patients tended to associate with their psoriasis skin disease severity over time. Now, what was very interesting here was to note that the type of coronary artery burden that is increased in psoriasis patients is actually non-calcified coronary artery burden. Now, non-calcified coronary artery burden, as you know, is lipid-rich, is prone to rupture, and tends to cause higher myocardial infarctions. So finally, what we got a takeaway from this study was that psoriasis patients tend to have this high-risk non-calcified coronary artery burden in their coronaries, which is elevated when compared to healthy controls, and this associates linearly with their skin disease severity over time. Our next slide shows our initial findings and the findings I just presented regarding our coronary CT angiography. We asked the question, how systemic inflammatory burden, as measured by aortic FDG uptake, associated with these non-calcified coronary artery disease parameters in the psoriasis patients. And indeed, higher the systemic inflammatory burden in psoriasis patients, higher was their non-calcified coronary artery disease burden. And this relationship persisted again after adjustment for traditional risk factors and other potential confounders. I think by now, what I've been trying to show was that we were able to show that psoriasis is not only a disease of the skin, but it affects or has systemic repercussions. It affects the aortic vasculature. It affects coronary artery disease. So next, we asked the question how multimodal imaging can be leveraged in the psoriasis patients to study the brain-heart axis and to see if there were any other systemic repercussions that we could see in psoriasis patients. So we hypothesized whether there was an association between chronic stress, as indexed by amygdala FDG uptake, hematopoietic systemic activity, as indexed by bone marrow FDG uptake, and subclinical cardiovascular indexes, as measured by aortic FDG uptake, as well as non-calcified coronary plaque burden. The design of the study is here. There were 164 individuals with psoriasis compared to 65 healthy controls. All of them underwent a PET CT, a coronary CT angiography, and 30 of the severe psoriasis disease patients were followed up at 1 year to see if their improvement in psoriasis disease severity had any effect whatsoever on amygdala uptake, bone marrow uptake, as well as their subclinical cardiovascular indices. What we found was indeed very interesting. Amygdala activity, as measured by amygdala FDG uptake, was higher in patients with psoriasis compared to healthy controls. Amygdala uptake associated with bone marrow activity, as measured by bone marrow FDG uptake, and amygdala activity also associated with aortic vascular inflammation, as well as non-calcified coronary artery disease burden. However, this relationship between chronic stress, as indexed by amygdala activity, and subclinical cardiovascular indexes was mediated up to 40% by bone marrow FDG uptake. A critical extension to this literature, which will be shown by my co-fellow Heather, was that we extended our findings into inflammatory myeloid pathways, which included monocytes, neutrophils, and platelets. And now I'd like to have Heather talk about the translational immunology efforts that she leads in the lab. Thank you.
Hi, everyone. I would like to also start by thanking you for inviting us to present to this group. It's really an honor to have this opportunity. So I'm a research scientist by training, and I'm here today to really demonstrate how we can leverage these imaging modalities in our lab to guide basic science research. So when I came into the lab about 5 years ago, we were implementing the deep immune phenotyping program in order to characterize immune cells in whole blood using flow cytometry. And what you see here is one of our initial findings, and that's that neutrophils are elevated in psoriasis. So in the top panel, we have our scatter plot from flow with CD15, our neutrophil marker, on the x-axis, and the side scatter on the y-axis. And if you look at the neutrophil population, you see that there's about a 30 to 40% increase in neutrophils in psoriasis patients compared to controls. So if you move down to the lower panel, this is shown in graphical form where, again, neutrophils are up in psoriasis. And then the next plot shows that CD62L and CD16 are both decreased on the surface of psoriatic neutrophils compared to controls. And so upon neutrophil activation, CD62L and CD16 are cleared. So essentially the takeaway from this slide is that psoriasis patients have abundance of neutrophils and they're in an activated state. Next slide. The next thing that we wanted to do was to target the neutrophil-associated proteins in circulation. So we measured the amount of myeloperoxidase, or MPO, S100A8 and A9, and neutrophil elastase, or NE-1. And as you can see from this plot, all of these neutrophil-associated proteins are up in circulation in psoriasis. And this here is an example of where we leverage our imaging modalities to understand how this actually relates to vascular inflammation. And you can see in the table that when we ran the regressions of the three proteins, only S100A8 and A9 was actually associated with vascular inflammation in these patients. And it held up in when both being adjusted for age and sex, and when adjusted for the Framingham risk score. Next slide, please. So again, to sort of reiterate what Amit said, the way I approached it was, as he insinuated, our patients, in addition to getting an FDG PET scan, they also get a CCTA, and I can take their blood and then target specific immune cell populations to sort of understand how these different immune cells relate to the amount of inflammation and coronary burden that these patients have. Next slide. Around this time, the low-density granulocytes were coming to the forefront of neutrophil research, and these are a pathogenic immature neutrophil subset that are up in lupus. And so what we wanted to do was we wanted to determine if these neutrophils are also up in psoriasis. And so what you see here is what's different about these low-density granulocytes compared to your normal density granulocytes is essentially in the name. They are less dense. So when you are processing your human blood on a FICOL gradient, they reside in the PBMC layer with your monocytes, B cells, and T cells. But from the surface, their surface markers are exactly the same. So we would use the same gating strategy to isolate them out. And if you look at the cytospin images, you can see that these are, in fact, your multi-lobe nuclear neutrophils. They're just coming out in different portions of the FICOL gradient. So when we look in psoriasis, one of the unique things about the way our lab is set up is that all of our patients also get a CBC. So we are able to take our flow cytometry percentage results and relate that back to the CBC and get the actual cells per microliter in these patients. So our normal neutrophils and our low density neutrophils or granulocytes are elevated in psoriasis compared to controls. But what has been interesting and has really withheld in most of our analyses is that when we run the regression, only the low density granulocytes are associated with your psoriasis area severity index score, which is just an assessment of the severity of their skin disease. And only these low density granulocytes are associated with how much non-calcified burden that these patients have in their coronary arteries. There was no relationship at all with the normal neutrophils. Next slide. So then the next thing that we did was we looked at another subset. So we wanted to ask the same question. We wanted to understand if all monocytes are associated with coronary burden or if there's a specific subset. And we took the same approach. We used flow cytometry combined with the CBC in order to characterize the cells per microliter of each monocyte subset. And we found similar results, that only the classical monocyte subset is actually associated with the amount of non-calcified burden in the coronary arteries of our psoriasis patients. Next slide. So this is a big jump here, and I don't want to lose you, so I will go into detail and explain to you how we go from immune cells to cholesterol efflux. But at the same time that we published that first paper showing that the neutrophils are elevated in psoriasis, we also came out, and this was back in 2015, we also found that cholesterol efflux capacity is inversely associated with non-calcified burden in these patients as well. So the lower their efflux, the more burden they had. And as a postdoc and a research scientist, what I really wanted to do was to take a step back and ask how each of these systems interlink. Because oftentimes we study metabolism, or we study the immune system, or we study the vasculature. And I'm really interested in understanding and taking advantage of these imaging modalities in order to understand how these different systems are linked. So next slide. So what we did was we stratified by efflux, and we asked the question, if we stratify by efflux, does the group with the lowest efflux value, we stratified by the median, does the group with low efflux values have increased activity in their bone marrow? And we were able to measure this by looking at the FDG uptake. And not only did they have increased activity in their bone marrow, but they also had a higher prevalence of non-calcified burden in their coronary arteries. Next. And the reason why, sorry, I left this out. So the reason why we went straight to the bone marrow is because the neutrophils and the monocytes are myeloid origin. And because these originate in the bone marrow, this is where we wanted to start. We wanted to go back to the beginning of where your immune cells are being produced. So that's why we focused on the bone marrow. And then we ran the mediation analysis. And what we found was that the bone marrow FDG uptake actually mediates 56% of the relationship between cholesterol efflux capacity and non-calcified burden. So this will sort of be the basis of the ongoing mechanistic projects that we will be doing in the research lab. Next slide. So in conclusion, these nuclear imaging modalities can be used to form the basis of understanding physiology and direct the mechanistic studies. In my talk, I highlighted 2 key immune cell subsets that correlate with early onset CVD and psoriasis and demonstrate possible linking pathways between lipid trafficking and bone marrow FDG uptake. And lastly, we would really like to highlight the very unique setup that we have here at NIH with the way that the DIR works. We are able to collaborate and to work closely with the clinic and the translational research teams in a meaningful way. And so with that, I would like to acknowledge our team. Dr. Mehta is our PI, and he's provided incredible mentorship, and he never runs out of forward-thinking ideas. And we also have Martin, who is our staff scientist and our team lead in the research lab. And then Andrew and Justin are our clinical leads. And Wunan is our staff clinician and also the organizer of this seminar series. And with that, we would like to take any questions that you may have.
Great. Thank you, Amy and Heather, for a wonderful talk. I don't see any specific questions in the chat box, so I'll turn it over to Dr. Sadeghi to see if you have any questions about the presentation.
So this is a great presentation. I mean, both presentations were great, and it's a very large body of work, very interesting. So there are some questions for Dr. Day, and maybe if you could address the issue of FDG specificity, and there are a lot of questions about what FDG really detects in the blood vessel, and whether you're looking at intimal hyperplasia, essentially pathologic intimal hyperplasia with aging and this psoriasis. How do you know that this is inflammation per se in the vessel wall?
Yeah, thank you for that question. I think it's a great question. FDG, of course, has been, I would say, been taken with some doubts regarding whether it detects pure inflammation, whether it detects certain aspects of inflammation, and so on and so forth. So I think there have been studies that show that FDG uptake in aortic vasculature is specific to CD68 positive macrophages and shows certain aspects that it is macrophage specific. However, whenever we do these analysis, we do keep in mind that there will be certain confounders that will affect FDG uptake in the aorta, and the best we do is try to adjust for those confounders. So all we did in this analysis was the best of our ability to adjust for all those confounders that could affect FDG uptake.
Okay, and then Another question was about the role of neutrophils. That was very interesting in psoriasis. It was increased. Are people using colchicine, for example, to treat psoriasis, which is a neutrophil inhibitor?
Sorry, which slide was that?
So that was about with Dr.
He was asking.
Talk, with Dr. Teague's talk, so that the neutrophils are there are more neutrophils in psoriasis.
And he's asking, guys, he's asking if there's been any creative use of neutrophil inhibition in this disease model or anything like that, and if any of you would like to comment on that.
So from my understanding, the IL-17 and IL-23 would be in the neutrophil pathway, but they wouldn't be direct targets of neutrophils. And I'm not sure about the colchicine specifically.
I love the question. Stay tuned. 4 years, 3 years, 2 years, not sure, but it's an excellent question. He's referring to Colcott-1, soon to be Colcott-2. We don't know if colchicine is a specific enough neutrophil inhibitor, but boy, I loved those results. It's now 2-to-1, right, for the inflammatory versus anti-inflammatory. So great question. We're thinking about it.
Great. So I think on that note, we're right on the hour. So with this, I conclude our session number 2 of our molecular imaging seminars, and we hope to see you next Tuesday from 11 a.m. to 12 p.m. Eastern Standard Time. The talk will be on new technologies and new cardiovascular nuclear cardiology. Thank you. Stay tuned.
Thank you.
Thank you, everybody.
Great. Thanks, everyone.
Thank
Great
you.
day.
Thank you.